Thank you so much for being here today for our webinar. My name is Donna Fishman. I am the director of the National Center for Children's Vision and Eye Health at Prevent Blindness. So I want to start with how grateful I am to all of our sponsors. Our lead sponsor is Janssen, a pharmaceutical company of Johnson & Johnson. We are Prevent Blindness, and then the Association of Clinicians for the Underserved and the School-Based Health Alliance. HRSA funds the School-Based Health Alliance, so we'd like to thank HRSA for their support also for this webinar. So we're going to hear from a couple of our sponsors, just so you learn kind of who are some of the players here in eye care for children and some of the resources that we have for you. And I'm first really excited to introduce Donna Hodge, who, as I said, is from Janssen. Donna leads the retina gene therapies business in the United States. And of course, we've already talked about how much we love that we have the same name. There aren't that many Donnas around. Her team has the mission to bring Johnson & Johnson's first gene therapy to market to help people living with inherited retinal diseases. And she has an entrepreneurial-minded team, startup mentality. She has a long history in marketing. She has her MBA from the University of Maryland and also has completed a new certification in Black executive leadership from McKinsey. So I'll start with Donna. Go ahead and introduce yourself, and then I will give you a little bit of background on my other sponsors because I know Donna has to run soon. So Donna, take it away.
Fantastic. Thank you so much, Donna. So good afternoon, everyone, and welcome to part 2 of the Prevent Blindness Eyes on Access webinar series for children's vision and eye health and community health centers. My name, as Donna said, is Donna Hunt Hodge, and I'm the Director of Marketing for Retina Gene Therapies at Janssen Pharmaceutical Companies of Johnson & Johnson, which serves as a very proud sponsor of this WebEx. At Janssen, we're harnessing our experiences in pharmaceuticals and our broad ophthalmology footprint to cover the full spectrum of eye care from the front of the eye to the back of the eye. We're pioneering advanced research, including gene therapy solutions that have the potential to transform the lives of people living with hard to treat, rare, inherited, and common retinal diseases. Janssen is focused on delivering breakthrough treatments that meets the needs of patients affected by common and rare forms of retinal diseases, such as IRDs, which affects about 165,000 people, including young children in the US. We really want to say thank you again to the Prevent Blindness, the Association for Clinicians for the Underserved, the National Association of Community Health Centers, the School-Based Health Alliance, and our panelists for your work in our communities to improve access to vision care for our children that is grounded in our shared commitment to support the eye health care of all. And our hope of treatment is on the horizon. I look forward to today's engaging discussion and learning how we can support the community going forward. Thanks again, Donna, and very, very excited about this webinar.
Thanks so much, Donna. And I apologize because I left off NAC's logo here, so I apologize, but I'm going to now introduce the other 3 sponsors of today's webinar. Paula Fields is the Senior VP of Consulting and Technical Assistance at the School-Based Health Alliance. And her work has really been in the area of school community partnerships, quality improvement initiatives. She's a nurse by background, and she has recently completed a long-term on the board of a community health center. Luke Ertl is a program director for the Associations of Clinicians for the Underserved. He's responsible for training and technical assistance to support health centers across the country. And he runs the ACU's Eye Health and Vision Care program, which I know he will mention more of. We have worked closely with Luke and with Brandon at NAC for over 2 years, bringing webinars and technical assistance to health centers across the country. So we're really happy you're here. And Brandon, again, I apologize about the logo. Brandon is the Director of Health Center Operations Training at NAC, the National Association of Community Health Centers. He has worked in C-suite in many areas, acute care, community health centers, and hospice settings, and he elevates healthcare operations performance through training and technical assistance. So really happy to have all you here, and I'll just go in order. And I'll tell you for a brief moment before I turn it over who we are at Prevent Blindness. Our mission is to obviously prevent blindness and preserve sight We have been in business since 1908, and we are really happy to be kind of one of the foremost organizations focusing on eye health equity in this country. So our national center was founded back in 2009. We're about to celebrate our 15th anniversary. We improve children's vision through strong partnerships, sound science, and targeted public policy. Our work is in the area of professional education, also advocacy, patient-parent education, patient empowerment. So we are a full spectrum organization. And wanted to mention, of course, our children's vision screening certification course for those of you who are interested in getting more expertise and a national certification. So that's us at Prevent Blindness. And I will turn over to Paula for a moment to introduce SBHA.
Thank you, Donna. As a nurse, mom, Mimi, and past administrator and board member, I'm excited to be here and remain a fierce advocate for school-based health centers because I've seen what it makes possible for students and including my own kids. With that, the School-Based Health Alliance is a DC-based nonprofit founded in 1995 and serves as a national voice for school-based healthcare. Our board of directors include a vast representation from leaders across the nation, including youth. And our focus really encompasses policy, standards, data, training like today, technical assistance, and consulting to support the work. So when we look at school-based health centers, there's about 3,900 across the nation. And there's a lot of room for growth to serve children so that they have equitable access to healthcare services. If you want to move to the next slide, I'll share a little bit about what school-based health centers offer in the form of primary care and often mental health, oral health, and vision services, and work really hard to coordinate and not replace existing services. Thank you for your interest, dedication, and work to support students' success. And it is my hope that you walk away today with some new ideas to consider in supporting children through school-based vision care. Thank you, Donna and team.
Thanks so much, Paula. And I'm sorry, I don't know what happened to my other slides. I'm so sorry. Luke, go ahead and I apologize. The slides somehow did not get into my deck. I think I must have the wrong deck, but go ahead and speak. If you will, you have yours up in front of you.
Sure.
I had
Good
them all
afternoon.
here. I apologize.
No problem. And of course,
Sure.
probably some of our links are, I'll talk you through some of the information. We'll get the links out afterwards for some of our resources. But my name is Luke Ertl. I'm the program director at the Association of Clinicians for the Underserved. And ACU is a transdisciplinary membership network uniting clinicians, advocates, and organizations working with America's underserved communities. We support thousands of clinicians and organizations each year with technical assistance, programs, and advocacy around clinical care, operational excellence, and equity. We began our work in the realm of eye health and vision services in 2017, and our work in the space primarily involves providing small grants and technical assistance to health centers across the country to help them start up or expand permanent eye clinics. Along with this, the development of our grant program in 2020, ACU started a Vision Services Committee, which is mainly comprised of eye care professionals from around the country who help guide ACU's programming and provide technical assistance to health centers when starting up or expanding their eye clinics. We also assist health centers with the recruitment of eye care professionals by providing free job postings on our Career Center. And we also have a number of different resources for health centers looking to start up or expand their vision programs. So you can check out our website, and the link or the QR code will go out a little bit later. And I'll drop the link to our website in the chat here in a moment. But you can see some of our different resources that we have, as well as a link to a Facebook group that has a lot of optometrists from around the country. With that, I'll go ahead and turn it back over to you, Donna.
Thanks so much, Luke. Sorry about the slides. And I do have Brandon's slides here. So let me just get into the right mode. And Brandon, go ahead and introduce yourself. I don't know what's going on with my mouse now.
Awesome.
Okay. Go ahead. Sorry about that.
Appreciate it, Donna. I'll be really quick. Brandon Jones here. Most of you may know me already, the attendees. Brandon Jones, I'm the Director for Health Center Operations Training at National Association of Community Health Centers. And really quickly, you've all seen the NAC mission before, I'm very sure, but I did want to highlight, though, again, that we serve as the leading national advocacy organization for community health centers across the country, member or not member of the organization. And we certainly support and encourage the expansion of healthcare access for medically underserved as well as the uninsured in our country. Our great colleagues here at NAC continue and conduct some ongoing research and analysis that really informs both the public and the private sectors about the impact of health centers. We also provide significant training, leadership development, and technical assistance to health center staff and health center boards to support and strengthen health center operations and governance overall. We work very closely with our alliances and our state PCAs or primary care associations to ensure that we're building stronger and healthier communities in their areas and also providing greater resources and investment in those communities as well. And moving on to our next slide, really quickly, just a couple of data points to show the impact. So I know we're going to be jumping into some really great content today, but I did want to take a couple of minutes to reset and contextualize the impact of community health centers and the power of the National Health Center Program. Many thanks again to everyone for your continued and or past health center service. As you can see here, health centers serve over 31.5 million patients at 1,400 funded organizations, health FQHCs and lookalikes through 15,000 service delivery sites. Our patients span across the continuum, many of whom are, I think 90% there, low income. We have some that utilize public programs, about 61%, about 41% of those live in rural communities, and another 19% are under or uninsured and or connected to special populations. And about 64% of those represent racial and ethnic minority groups. So again, thank you all for your continued health center service and or past service with us. And as we close in our last slide, I did want to provide you just a couple areas on our social media platform. We are present at all platforms there. Our communications team has recently been revamped. We've got some great leadership on our community's communication and meetings team now, and they're constantly updating all of our social media platforms to ensure that we're showcasing all the great work that health centers are doing every day in their communities. Additionally, for more information and data and also some valuable kind of infographics that you can download, please visit our main website at nac.org, and you can click on that top tab that says Research and Resources. It gives you some really invaluable kind of quick print, quick share, downloadable infographics with a ton of data that shows the health center impact. Thank you again to Donna and Prevent Blindness team and ACU for all the continued partnership with us on this great work. Thank you.
Thanks so much, Brandon. And one thing I do want to mention that NAC, we're so grateful, hosts a clearinghouse that has all the links to all of our webinars and materials. So we'll be sure to send that out tomorrow also with some of the follow-up information. Let me get back to my other slides now. Sorry about. Okay, so I'm now happy to introduce our moderator for today, Dr. Stacy Lyons. Dr. Lyons is a professor of optometry and serves as the chair of the Specialty Care and Vision Science Department at the New England College of Optometry in Boston. She provides pediatric eye care at the Charles River Health Center in Brighton, Massachusetts. She's also, I'm proud to say, the chair of our National Center for Children's Vision Eye Health, our advisory committee. She's a past chair of the Vision Care section of the American Public Health Association and co-director of the Massachusetts Opening Eyes program as part of Special Olympics, and a member of the Children's Vision Massachusetts Coalition. She's also served on the advisory board of Women in Optometry, and we're so lucky to hear from her today and for her to lead our webinar. So I'm going to turn it over to Dr. Lyons. Thank you.
Thank you so much, Donna. And just as the Donna said originally, this is the second webinar that we're hosting. And I'm very excited to be hosting again today, and very excited to see the diversity of our audience today. As I was going through the questions, the burning questions that you had put together, I wanted to share that we'll have time for questions and answers later, although I have a feeling that many of the questions that you have might be answered just from our presenters today that I'll introduce in just a moment. If you want access to our first webinar, I believe Anne is going to put the link into the chat so you can access that with any information if you didn't manage to get to that particular webinar. And very excited to talk today about different models of vision care for children in community health centers. So our panel, Dr. Diedrich Dacke is a practice administrator and vice president of optometry for MCR Health in Florida. MCR Health is a multi-specialty community health center with over 40 locations and 15 subspecialties. Dr. Dacke has participated on various committees, including the Clinical Performance Improvement Committee, the Senior Leadership Committee, Insurance and Quality, just to name a few. Dr. Dacke has committed to training and developing leaders and plays an intricate role supporting MCR health and patient care. Dr. Dacke is a graduate of the University of Central Florida and has earned his doctorate of optometry from the Nova Southeastern University in 2012. He then completed a residency in primary care and low vision from Lake City VA Medical Center in 2013. Prior to committing to the community health care, Dr. Dacke has experience working in an ophthalmology practice and retail optometry. Welcome, Dr. Dacke. Dr. Lindsay King is an outreach optometrist at Health Partners of Western Ohio. Dr. King received her doctorate of optometry degree from The Ohio State University College of Optometry in 2014. She helped build the full scope vision care practice at Family Health Services of Darkey County, where she served as co-director of the eyecare department from its inception in 2016. This past April, she made the move to Health Partners of Western Ohio. Here, she is the outreach optometrist in the Lima, Ohio area. Her main role at Health Partners is to operate a mobile optometry unit that serves children by working with their school nurses and arrange comprehensive vision services at school buildings. She has a deep passion for extending comprehensive eye care to those in underserved communities and those with limited access to care. Welcome, Dr. King. Next, we have Dr. Jackie Pacusa. She is a pediatric optometrist practicing at Neighborhood Health, a federally qualified health center in Alexandria, Virginia, where she also serves as the Associate Director for Vision Services, having joined the team in order to establish the Vision Services in 2022. She completed both her doctorate and residency in pediatric optometry at the New England College of Optometry in Boston, Massachusetts in 2013. Dr. Pacusa previously served as clinical faculty at Children's National Medical Center in Washington, D.C., and at Children's Hospital of Pittsburgh at the University of Pittsburgh Medical Center. She is passionate about preventing and treating conditions affecting children's vision and the quality of life, and about bringing the highest quality of eye care to individuals with various special healthcare needs. Welcome, Jackie, and very exciting, as Jackie was my student and resident a long time ago. Carrie Van Pelt is an office manager and licensed optician at Vision Centers of the Euler and Academy of World Languages schools in Ohio. Ms. Van Pelt is an accomplished professional with over 27 years of progressive retail, volunteer management, and optical experience. Since 2013, Ms. Van Pelt has been working as a managing licensed optician for the Cincinnati Department of Public Health, where she has operationally responsible for opening and managing the first school-based vision center within a school in the nation, along with the expansion of other sites. Prior to that, she was the senior operations manager of one site and was responsible for managing and supporting North American Luxottica store programs and sustainable vision services for the underserved. Before joining OneSight, Ms. Van Pelt was the general manager for LensCrafters with operational responsibilities for 6 optical retail locations. Throughout her career, Ms. Van Pelt has shown a proven ability to build and motivate cross-functional and community-based partnerships and provide customer service excellence. Welcome, Ms. Van Pelt. So we're going to kick it off right now with this fantastic panel, and I'm excited, with really talking about 4 models of eye care in schools and in communities. We'll follow that with some questions and answers, and then we'll end with some resources. If we don't get to all your questions and that you have, we will probably send out an FAQ at the end, so you can get those answers. So let's start by Dr. Danka. Welcome.
Good afternoon. Thank you so much. So I'll go ahead and get my screen shared. So give me just a second. Okay. Presentation active. Hope you guys are having a great day. Really excited to be here and share a little bit about our practice. So while I'm getting this loaded up, I'll talk a little bit about MCR Health. So MCR Health, we're located in Bradenton, Florida. And thank you so much for the kind introduction, and thank you to the Eye Access and Prevent Blindness team for having us, because this is a great, great resource. So one thing I'll share is that we really are fortunate as a health center. When I joined MCR Health in 2016, at that point, they had already had eye care for well over 15 years. So that background really allowed us to kind of take that and build upon it for the development of our programs. So my presentation today is going to be focused on, and before moderators, do you guys have the presentation or? No. There we go.
Yes, we can see.
Perfect. So we had a really strong foundation, which allowed us to expand into children's vision services and school-based healthcare fairly easily. MCR Health has 3 eye care sites. We had 2 brick and mortar locations, and we also have a mobile unit that we've been operating for over 10 years. And it's kind of gone through different iterations. At one time, it was used kind of sparingly, and later we really started to run it as a full clinic, 4 or 5 days a week. And as COVID kind of hit with the social distancing, it became challenging to run the mobile unit in that fashion. So we kind of pulled it away and kind of focused our mobile unit more on screening events and school-based healthcare. So that kind of leads to where we are today. All right. So MCR Health, who are we? Like they mentioned, 40 kind of centers, but really we say 25 health centers. Some of those are split between family and behavioral health, or family and dental, or peds and dental, and a lot of them have pharmacies as well. 100+ providers. On the family side, we can see over 400 patients a day, and on the pediatric side, we can see 300+ patients per day, including extended hours and like what a lot of the health centers are dealing with. So we were founded in 1979. We service Manatee, Sarasota, and DeSoto counties here in Southwest Florida. As I mentioned, multiple specialties, family peds, OB, dental, BH, and many subspecialties, ortho, podiatry, cardio, pulm, dermatology, infectious disease. So this makes it kind of cool because a lot of our specialists deal with similar issues that we deal with regarding authorization, payments, working with specialists within a healthcare center because some specialists maybe not be used to the requirements or all providers. So we're kind of accustomed to dealing with those challenges. All right. So today I'm going to kind of be focused on school-based healthcare. So the first thing is the partnership with the school district. MCR kind of had a big commitment, top to bottom, with launching our school-based health center. And you kind of can see one of the trailers in the back of the photo. So it's MCR Health Southeast High School. So that's one of our healthcare facilities where we offer pediatric care, and also there's another portable that offers behavioral health care at that facility. So you also can kind of picture our mobile unit, right? So you kind of get a picture of the mobile eye care unit. We did have it wrapped. The benefit of the eye unit, and it's really a marketing tool. You know, it kind of highlights the company. A lot of people recognize that, oh, I saw the mobile unit going here and there. So it's a good thing for a healthcare facility. But in order to get a school-based health program established, you really need buy-in from the school district. So all the tools and resources kind of providing to them on how beneficial it can be, and providing the access. You know, us having a healthcare facility, being here since '79, you would have thought we've seen every kid in the region. But it's so interesting, when we go to these schools, there's so many first-time patients that we see. So a lot of patients don't have the access to get there, whether it's them getting there, them not understanding the insurance, or maybe the parents not being able to take them. When we do these deployments, we're really seeing a lot of patients. But it really starts with the school district, having them understand that this is a service that we can provide. It's mutually beneficial. You know, we know healthcare well. They know how to take care of their students well. And if we can kind of get on the same page, we offer a great service. So the communication and marketing, we have to really be really clear on the services we're offering. And I think I'm gonna get into the actual screening later. But a lot of times when they say, okay, we're gonna do screenings, the schools and the people that you're offering services to really need to understand the difference between doing a free screening versus providing comprehensive exams for patients at school locations, right? So screenings, that's fine. It's a good tool to kind of get name and information out about your company. But in those situations, those are more tailored towards big events where there's a lot of visibility, maybe a lot of people that may be interested in later becoming patients. The screenings are a different thing. When we run those types of events, we want to make sure that we have consents and insurance and information and our pre-screening questions so we can run an efficient and effective service. But the communication and marketing is really one of the biggest things that kind of generates. With our particular school district, on the school district website, it highlights MCR Health and our school-based services. So, you know, establish with a pediatrician, establish with BH, get dental and eye care. So we kind of have already generated good press. When we opened our services, our leadership team was in the news. They did news press releases, newspaper, on the actual TV news. So there was a lot of positive buzz, and it's a thing that in our community, they know that we're a pioneer of. But really getting the patient volume there is a big part. So the consent process. So this is a unique and interesting part. So on my end as an eye doctor, right, we lean heavily on our grants team, on our contracting team, on our outreach team to kind of build the formula for consent. And we have the benefit that we already have a school-based program that has a consent. It's just readapting that to vision, right? Or maybe having a separate questionnaire that can kind of give the providers that are providing those services what they need to be successful. And lastly, focus on the school-based health. The school-based nurse is your best friend, right? So we talked about how you kind of have to go top down and make sure your CEO and the principal and the school district leadership is all on board. But when it really comes down to running these services, your relationship with your school-based nurse and those day-to-day changes and getting the information to the student and getting the information to the parents, that has to be, you know, between your manager or your main provider. It really, when you're leading up to these events, you almost have to be on a text basis because something always comes up. And that's how we've been able to be successful with that. All right. So sharing a little bit about our particular mobile unit that we use, I shared with our dental team. They have a mobile unit as well. You can kind of see the similar design language that we have. And in the background, you have the eye care unit. So a few things. You noticed in both of these pictures, we have tents. We are in Florida. It was quite warm this year. We have tables and chairs, right? And if you look at that dental picture, right where the D is, there's actually a lift that will make the unit compliant to any patient in wheelchair or with any mobility issues as well. So we have 2 exam lanes, one to the anterior and one to the posterior side of the unit. And when you first walk in, there's a check-in station. Further along, there's a better picture of the inside as well. So wireless connectivity is definitely something that is a major issue, right? Because we are in electronic medical records. So our IS department really has a heavy part of that, but that's something that definitely has to be considered. We've had some networking built into the mobile unit, and we've also used just kind of a mobile hotspot jetpack that connects to all the computers. But almost with every event, we do a call down with our IS department to do a testing and making sure that it's running, especially since it's not running daily. So awning. The dental unit, there's a window. Above that, you may see a little silver strip. That's an awning that kind of can come out. So in this case, it's not out because there's a tree, but that makes it a lot easier because the railing doesn't get too hot, and it kind of makes, it just gives it a nicer appearance, and it makes the unit look situated when we're presenting. One of the things that makes this program successful is we have a very strong facility team, right? They take care of the general maintenance, but also we have expensive medical equipment on the unit. So there's a lot of kind of thought that has to go into checking things, making sure they're right. I have a teammate go to the unit once a week. So they do the making sure the RV unit, the van is functional. Then I have a teammate go through, hey, you get off an hour early, check all of our equipment, turn all the computers on, shut them down, make sure everything's gone. So that's something that we have to kind of consider to make sure we're successful. Staffing optimization, right? So I mentioned in the past, it was running as a full site. And now we're kind of deploying as needed, right? So we kind of have a 1.5 staffing model at our main clinic. And that staff is working their own referrals and kind of handling a lot of duties in the clinic. But when we go out, 2-3 times a month, that's the team that deploys. And we were able to actually train our mobile bus driver, the guy that drives the bus. He was bilingual, and at a moment he was helping. So we would have a patient coming to get glasses. So he would help them get the glasses, and he would help translate. And later we said, hey, you want to learn how to adjust the glasses? Well, he learned how to adjust the glasses. Well, later he said, well, you know what? Can you get these auto refraction, which is a part of our pre-testing? So you learn how to run the auto refraction. Long story short, he ended up learning how to do everything in the clinic. So we got him trained, competent, and now he's a full-fledged technician, which would allow for us to kind of essentially eliminate a position and, give back to the community in terms of paying him more to kind of do both jobs. And that works really well. The unit was started with a grant. That was prior to me joining the company, but there was a funding component to get that. So definitely look into the opportunities with that. All right. Oh, here are pictures. So this is a quick picture, and I'm staying on track, and I have a few minutes, 1-2 minutes left. But this is a picture of the inside of the mobile unit, and you can kind of see the auto refraction. One of our technicians, you see the auto refraction desk, the check-in desk in the middle, and the optical desk in the back. On the other picture, you see the actual one of our drivers, a desk where we fit glasses, and a kind of look at the layout. That's pretty much it. So providing screenings, definitely coordinate with the locations, right? Definitely put some thought into your setup. It's a mobile setup. You want to go however often you want to go. You want to have preset marketing material to promote the company and make it fun. So that's kind of that part. So I spoke on the screening versus exams, spoke on the nerves. Oh, that's the exam flow. So we use 2 to 3 staff members, a check-in, a technician is a definite. If we're very busy, we'll put a third to kind of run the optical in addition to the provider. And we do run a 20-minute schedule. So we have a patient every 20 minutes. If it's younger, maybe we'll kind of plan some breaks, so like a dummy slot. But this is kind of the full speed for us. And after the exam, I typically will have my main supervisor or manager kind of coordinate, reach out to the school, see if there's questions, and we send somebody out to dispense the glasses about 2 weeks after the deployment. As you guys know in eyecare, if you get a self-pay, you can send them some places, but certain insurances cause you to send the glasses to a particular place. and they can take 3 weeks. So we try to wait till everything's in and make one deployment out to the school for fitting, which doesn't include a provider. So to wrap, how do we become successful? Clear expectations on our services, advanced planning, making sure our leadership team, our execution team, and the school team is on the same place, and regular communication as we kind of lead up to it. And remembering that these kids that, you know, we see that maybe would not have gone or maybe didn't know the importance, when the nurse pushes it out to all students and they say, oh, we have insurance, it's free, and they go, and then you find out that they had a big problem or making a big impact. That's it. I think I have a few minutes for questions.
Thank you, Dr. Daka. And we're going to actually do questions at the end. And
Okay, perfect.
there are definitely a number that have come in, and there's no doubt that building strong relationships with your educational and school health professionals is really key. So thank you. Next up, Dr. Lindsay King, and she's the outreach optometrist at Health Partners of Western Ohio.
Thank you, Dr. Lyons. Let me get my slides pulled up here. All right. Can everyone see my slides there?
Yes.
Yeah.
Okay, good. All right. Well, thank you for the introduction. And like Dr. Lyons said, I'm Lindsay King. I am the outreach optometrist at Health Partners of Western Ohio. Right now, our vision outreach services, we have 3 complete vision outreach teams. We see patients in the Toledo, Ohio area schools and the Lima area schools. Our teams are kind of made up of, each team has 1 optometrist and a receptionist, and then 1 or 2 opticians. It just kind of depends on the caseload at the school. If we have 1 or 2 opticians that go to the site. As of right now, we do just vision outreach. We don't have brick and mortar at this point. When we go to the schools, we have demo frames that we take with us for the children to see. And I have pictures at the end that you guys will see for those, or see of those, kind of our setup and everything. Those frames are specific to the different Ohio Medicaid plans. I'm not sure in other states, but in Ohio, we have different managed care plans with Medicaid, and each plan has different frames that are covered under that plan. So we have a wide variety. However, because we are limited on space, we can't carry every frame that is available. So we also have a book of photos in color with additional frames for children. And that book also lets us know what other color options the frames that we keep with us are available. So for some reason this year, blue seems to be a very popular frame color for kids. They always ask if they can get something in blue. So it's really quick and easy for, you know, my optician that's with me to say, oh yes, this frame comes in blue, or, oh, the front of it's going to be in black, but the temples would be in blue. Blue and red seem to be our 2 most popular frame colors this year. So it is really nice that we have that book with color photos in it that we take with us, in addition to the demo frames that we take with us. Our full-time vision outreach services are 4 days a week in the schools. And on that 5th day, as it is said, we rest. No, that's not really true. We don't rest. We are always at work. On that 5th day of the week, we prep our schedules and supplies for the next week. We go back to the previous schools and dispense the glasses that have arrived. I will return to the previous schools for follow-ups as needed, check on any amblyopes or lazy eyes, any prescription follow-ups or rechecks that I need to do. Or I'm doing kind of some downtime stuff as far as admin type work, like sending referrals, contacting parents. We really work, and since it is kind of a smaller department as far as our entire health center is concerned, we really work closely and help each other out. So, you know, if my receptionist or my optician needs help with something, we all kind of help each other out with contacting parents or that kind of thing. I'm very hands on. I always have been. I really like to call and talk to my parents about things. So when I flip through or when I'm done seeing kids at the end of the week, um, if there's something that I feel a parent really needs that I need to speak with them more on, I always keep those kids off to the side. I send myself a task in our EHR so that I can call those parents back and explain whatever condition it may be or why I'm going to see their child back in 3 months or so to follow up with them. The work duties are, of course, like I said, we help each other out. Some of these lines are a little blurred just because we do help each other out a lot. But my receptionist, she is the main point of contact between the school and our team or the health center. She sorts through all of the consents that we receive. She registers those children if they haven't already been seen by our health center, or isn't already registered in our system, like they haven't been seen by our vision outreach or dental outreach team in the past. And she puts them on the schedule for when we're going to be at that school. She's responsible for checking the insurance coverage prior to our site visit at that school. And when we're in the schools, she checks the child in and out on the day of that site visit. My optician she's also my tech, so she performs the pre-testing, autorefraction, tonometry, stereo, and color vision. She also is responsible for helping the child select glasses if needed. And again, is also the one responsible for knowing which glasses are covered by insurance. She orders and submits the glasses to the patient's insurance. I should also say my receptionist is being cross-trained currently as a tech so that as my optician is submitting the glasses orders, we can keep a nice flow of patient care so that my next patient can be pre-tested while she's finishing up that glasses selection with one child. My optician also checks the glasses in at our home base location. And then she is also the one that returns to the school to dispense the glasses. Obviously, my role is to perform the comprehensive exam. I send the referrals to the specialists if needed. That's just my personal preference. Again, I do like to be more hands-on with those kinds of things. I do believe our other two outreach optometrists on our team delegates that task to their receptionist. I cannot tell you why it's my preference to do that. I probably am a rare breed in that aspect, but it is just my preference to send those. Um, and then also perform any follow-up treatment as needed. And in regards to returning to the schools for those follow-ups with the kids. As far as working with the schools, as Dr. Daka said, that school nurse is your best friend. The way our outreach operates, he or she, the school nurse, is our main point of contact. We send our consent forms to the school, and then the school nurse facilitates getting those to the parents and collecting them back. Those consent forms explain the process. Health Partners has dental and vision outreach services. So we do a shared consent form. The top of the consent form has a dental box, a vision box, or a both services box where those parents just check which service they would like their child to receive or if they'd like both of those services. It also explains dilation will be performed, glasses will be selected, and then other dental things that happen. I'm not in the dental world. I don't understand all the dental terms, but it explains, sealant may be applied and those types of things. So all of that is on one form. The nurse collects those and sends them back to my receptionist prior to us scheduling that or prior to us going to that school. Because our dental outreach has been established for about, I want to say over 15 years at this point. We know roughly how many children are going to be seen at each school that we're going to. So we know roughly how much time we need at each school. Sometimes it's only 2 days because it's a smaller school. Sometimes we need 2 weeks, those, 4 days for 2 weeks consecutively. It just depends on the size of the school and the need at that school. So based on the number of children at that particular school and the number of children that have been seen in the past, either by our vision team or by that dental team, we build out our schedule for the year. Our patient population, we see school-age children. The vast majority are covered under Ohio Medicaid plans or are uninsured. We do have a lot of Haitian and Dominican migrant population in our area, so we do see a lot of those. We are located here in a little bit more of an urban situation or urban setting, but we do travel out into some of the more rural schools as well. When we're going into a school, the week prior to going there, we do ask the school nurse if she has a list of any, I keep saying she, I apologize for that. All of the school nurses we have worked with thus far have been females. So it is habit to say that. So I apologize. Um, but we do ask the school nurse to provide a list of any students that have failed the school vision screening, are on an IEP, or any students that just the teacher has had concerns with, for two reasons. One, we're going to make sure that we prioritize those students and see them early in the week or put them on our schedule early in the week in case there's absence, illness, or even potential schedule conflicts when we get to the school. Testing happens and pops up, things like that that could get in the way of us seeing that child early in the week. We want to make sure we get them on the schedule while we're there, because in our area, there is one other doctor that sees Medicaid. So it is us and it is this one other provider. So we may be that child's only chance to have an eye exam. So we really want to make sure we see those children. This is just a rough outline. Well, it is the exact number of the patients served in our vision outreach. In the 2021 to 22 academic year, we saw 27 schools. We received just over 2,200 consents and did 1,200, just over 1,200 exams. 780 of those received glasses. In the 22 to 23 academic year, we went to 38 schools, almost 3,600 consents, 2,000 exams, and 1,300 glasses. Since this is our, I believe, third full year of vision outreach, we've increased our program size from about 2 full-time equivalent staff to almost 9. When it first started, we just had one doctor and one optician that did 3 days a week in the schools. So we really have increased and are continuing to increase. We actually are expanding even further into our southern area at this time because of the need there. And so it really is definitely a need. As far as community support, I've been a part of expanding vision services in 2 different health centers in very different parts of the state of Ohio. One was more of a rural farming town community, the other, this one, in a city and urban setting. I've never received any pushback from community members in the expansion of these services. The medical and the optometric communities and the health center and the rest of the community, they're excited to have us there. They know these children need us there. They need our services. If you educate the local agencies and the providers on what you're doing, like Dr. Daka had mentioned as well, make sure they understand you are not there doing a screening. We are there doing a comprehensive exam. As of right now, we don't go in and do screenings. One of the big pearls here that I wanted to relay is that in the state of Ohio, school nurses are required to perform mandatory vision screenings. And our comprehensive exams that we're doing do not replace those per the ODH or Ohio Department of Health requirements. Also, when you're starting this up, just be prepared to work through bumps with Medicaid. It does sometimes take a while to get accounts set up and that kind of thing. when you're asking for sizes and styles of demo frames, be specific. Go through the catalog first. Go through what's offered. When we first just asked for demos, they gave us maybe 10 frames. That's not going to cut it, especially for the number of children we see, the ages and sizes that we see. So we had to go through and be very specific. I want this frame, I want this color, this size. The other thing is, we are fully mobile right now. We are not mobile in the sense of having a van. We are getting one, which I'll show you a picture of. But right now, we move all of our equipment into the school and set it up. We tear it down and move it out after our week of time. So having totes that stack it on wheels are critical. We found that Craftsman trade stack products are really helpful, or just other toolboxes that are on wheels. When we go, we have a carbon copy form that provides an exam summary to the child. It also has their glasses prescription at the bottom. I handwrite the prescription in at the bottom. There are check boxes that I mark. Your child had a full exam. Healthy. Healthy. Their eyes were healthy, or there was an eye health issue, and I write in. They were farsighted.
Sorry for interrupting. You've got about 30 seconds. I just want to say you have 30 seconds. So how about we just send your pictures out? Finish your last point. Then we'll send
I'll do the pictures. Okay. That's fine. So you can see here, this is my mobile phoropter on a stand with a table. My keyboard operates my eyecare chart. Here are my glasses trays. So you can see, and there are 2 trays under this one. So here are our trays of glasses. And then these are the trade stack Craftsman toolboxes. And then this is what our van's going to look like. We have 3 on order, 1 for each team, 2 are being built right now. They're really hard to get a hold of right now. So if you think you're going to want one, order it now, because they're in rare supply. That's it.
Thank you.
Yeah.
And I think you touched on a lot of questions that people have been asking about this front end and back end, getting the consents and that, how that labor intensive that is. And there are lots of questions. We might have time at the end to catch you then. Thank you. Next, Dr. Jackie Pacusa.
You're muted.
Thank you, Donna. All right, so thank you so much to our host for having us today. This is just such a wonderful opportunity to get together and share ideas, and I'm just really thankful and excited to be here. So I wanted to talk a little bit about our pediatric optometry program at Neighborhood Health in Northern Virginia. We just celebrated 1 year of seeing patients in our new vision services clinic. And I'm the Associate Director for Vision Services. I joined here just a little over a year ago to start up our services. So next slide, please. All right, so this is taken from our annual report from 2022. We just celebrated 25 years as an organization in Northern Virginia. And you can just see, I just pulled some stats here. So last year we served over 34,000 patients, and you'll see that approximately 1/3 of them are kids, so ages 0 through 17. Something that I thought was really interesting and great to contrast with the statistic that Mr. Brandon Jones pointed out. He said about 19% of CHC patients nationally are uninsured. And if you look at our insurance status there in the lower right, 45% of our patients are uninsured. And if you break that down by ages, you'll see that the kids, so the minors, so 18 and younger, are going to have insurance at a much higher rate than the adult population. So the kids are more around the national average, whereas our adults tend to be more often uninsured than insured. A little more than 50% are uninsured. You'll see the pediatrician here on the cover of our annual report is our medical director, and she's my boss, and Marty Wellman. She's a wonderful pediatrician, and she connected with another optometrist, I think, through one of these ACU webinars, and we had a mutual connection. That's how Marty and I met each other, and I eventually joined Neighborhood Health. Being a pediatrician, she has, of course, a a really great understanding of the needs for kids, just even to receive basic glasses, as she had put it to me when we had our first conversation. And then of course, kids who may have various special needs or developmental challenges, or something else going on, even if it's vision development, amblyopia, preventable blindness. She saw that the kids were just not able to access the glasses. They weren't able to access the full exams, even when they were failing their screenings. So next slide, please. As you'll see, last year, our health center provided over 120,000 healthcare visits. We began our optometry services in Q4 of last year. So within that short time period, we had our 318 visits, but that's 318 more than we'd had before. And we are Joint Commission reaccredited last year. Very proud of that. Next slide, please. All right, so a little bit about our service as we envisioned it. Dr. Wellman and I had envisioned the service at first as potentially serving the kids and the adults from the get-go. And then we realized that bringing on one provider, we were going to not be able to really meet the needs of the adults as easily if we were to just start, because the need is really so great. And there are, in fact, some other services in the area that can meet the needs of adults, charity services, services that contract with Medicaid. But for the kids, especially the kids who are ages 6 and younger, a lot of times, even if they do have Medicaid, they just can't find providers in the community who are able to or feel confident or are willing to welcome that population to their practice. Kids would be on wait lists for 4 and 6 months at the Children's Hospital, where I actually worked about 10 years ago. So I know they were waiting to see.
She seems to have frozen for a moment. Thanks for your patience, everybody.
Oh, are we back?
We're back.
Yep.
When did I freeze? Where should I start from?
Only about 10 seconds.
Oh, okay, great. So I was just saying that the kiddos in our community, especially those who are ages maybe 6 and younger, are even if they do have Medicaid insurance, are often not able to access care, even if they have transportation, even if they have health literacy, simply because the providers are not there. If they wanted or needed to go to a children's hospital, which oftentimes really should be probably directing their limited resources to kids with more intense needs or more significant problems, the kids who may need glasses or may be served well by pediatric optometrists were also on that list and waiting 4 months, sometimes longer, to get in. So this was a great opportunity that Marty Wellman presented to me to meet the kids where they are. And so we decided, let's focus on seeing the kids at Neighborhood Health for, to get our program up and off the ground. So also for sustainability, due to the payer mix that we touched on earlier, kids having a higher rate of being insured worked well for getting a nascent program and working through getting that off the ground. So we are currently limiting services to neighborhood health established patients ages 0 through 18 years and who, oh, pardon, just getting distracted by a pop-up there. Okay, who are referred to us by their pediatrician or who can self-refer. So if a parent wants their child to be seen by me, they have a kid who's an established patient at Neighborhood Health, then they can see me regardless of insurance status or if they're uninsured. And so our eyeglasses, one thing that Dr. King touched on, getting our eyeglasses program up and running, we've really relied on a charity source of eyeglasses, which has been fabulous for us, actually 2 major charity sources. And it has taken some time. It's been surprising because although we already contract with Medicaid in a lot of different ways, the vision services part of that has presented some challenges in getting paneled and getting up and running with them. But thankfully, the charity service has allowed us to provide glasses to the kids who need it. And then the kids who do have Medicaid, we present them with a list that we have pulled from a web search of their individual vision service provider or vision insurance provider through their Medicaid in the community where they can go, and we can help them access that. The eyeglasses. Contact lens services really limited to medically necessary case. I have a handful of kids who really require contact lenses in order to address their vision needs. Otherwise, if kids want to, they can go into the community and pay out of pocket and seek that service. But just because it's just me, and now in the past 6 months, we've had our technician, John, joining us. We don't have the time to see kids just for, contact lenses electively. Myopia prevention and management is something that I feel really passionate about, and any of our eye care providers here understand the impact that this has on the lifespan vision for the child. And so, myopia prevention and management truly is blindness prevention, and I believe that it's a crucial thing to bring to the public based on the global pandemic of myopia that we've been experiencing, which was unfortunately exacerbated by the COVID-19 pandemic and kids needing to be indoors and doing a lot of near work. So we've already got our myopia prevention and management program up and running here. We co-manage and refer to pediatric ophthalmology. There are some groups in the area who have pediatric ophthalmology aside from the hospital, and so we'll co-manage with them for those cases that really do need that type of care. As I mentioned, I served solo for the first 6 months, so we did have the front desk checking in the staff, the kiddos, and fortunately they already have their visit in the EHR from their pediatrician. So then I would be the tech and the optician and the optometrist. And now John is here, and so he is doing some of the workups. He's doing a lot of the technical aspects. He's ordering all the glasses. He's quality checking the glasses and dispensing them and adjusting them. And he's learned so much in just a short period of time. Our schedule presently accommodates 13 pediatric optometry visits. So we do 8 in the morning and 5 in the afternoon. A lot of times when you're dealing with kids and families with multiple young kids and kids with special needs, that can run behind. And so I like to front load the morning so that, if we need to work through lunch, or I need to work through lunch, I don't make John work through lunch, but if I need to work through lunch, I will, and then I can sort of catch up later in the afternoon on things that need to be done. The adult eye services that we do offer photograph retina screenings for diabetic retinopathy. So existing patients living with diabetes who need to be screened. And so we do 16 per week, and John takes those photos, uploads them, I evaluate them, and then we make referrals as needed to the community. I do some curbside consults. So primary care physicians in our group and I will chat and decide, even if it's an adult, how do we need to manage this referral? How urgent is it? And our future aim is to add adult services and expand as well. All right, next slide, please. Okay, so we do have here, this is Richmond Highway. So this is a location in Alexandria where we first began services. And the blueprint that you'll see is an upgrade that's happening as we speak. So there's currently construction happening, and we look forward to moving back in there. When we started a year ago, it was still the same area, this little blue highlighted area with the 2 rooms, but there were no other services being provided. This was more just offices, and now it's being renovated so that once our beautiful new space is open, it will be co-located with prenatal care and pediatrics. All right, next slide, please. Okay, so these are some pictures of when we just started. We knew it was temporary because we knew the construction would be happening. In the top left, you'll see Kevin Track, he's just started his first year of osteopathic medicine school. So I'm really excited and proud for him. He has an MPH, and he helped me with so many aspects, which is another awesome thing about being at an FQHC. You have passionate people with so many skills. And so Kevin's here helping me set up and test our equipment. You'll see the little butterflies on the ceiling. That's just a pearl. I love to put the little butterflies on the ceiling because it helps with that drop installation to give the kids something to look at. All right, next page, please. And this is where I'm sitting right now in one of these blue exam rooms on the bottom. So this is our neighborhood health at Annandale location in Annandale, Virginia. And we started here at the beginning of August, so we've been here for a few months now. And then once the construction is completed at Richmond Highway, we plan to split our time and then hopefully offer space for expansion as we grow our team. And we're co-located with a wonderful team of family medicine and pediatric medicine, and then sometimes dental medicine even comes in here. And we have some outreach, community health outreach for the Ryan White team. So STI prevention and education. All right, and next slide, please. And this is where we are at Neighborhood Health. So we've got our little, our tech room and our exam room side by side. And next slide, please. This is John's tech room. So this is where he does his many different functions for us. If you'll see on the right, I just have that little scan mate because I think that this deserves its own picture. This is part of our myopia management program. So the scan mate costs maybe a couple $1,000s, maybe can't remember the exact number, somewhere in the 2000s, I think, as opposed to some of these really potentially prohibitive, models that you'll get, which are really fancy, 10 or more times that. But to have a myopia management program, I really believe you need a staff, an eye care provider and a staff who are trained in it, and something like this to measure your axial length. You could technically get it started even without that. Axial length management, but to give the best care, that would be my recommendation. All right, and next slide, I think our final slide. Oh wait, that's just
you've got about,
exam room.
You've got about 10 seconds if you
Perfect. Just our final slide will be perfect. One more. Okay. Oh, nope. Okay. So this is our free book program. You'll see in the top right, that's John Torres Vasquez, my technician, assistant, optician, photographer. We've got our nurses and MAs. So these are books donated from some community organizations. And given that we serve a population who are often coming in as, newcomers to the United States and may not have a lot of books at home, or just could like to infuse some fun into their library at home, this really brings a smile to my face every day. And that's Mark from Facilities putting together our bookshelf. All right, thank you so much.
And I love that, Jackie, because thinking about, learning to read and its connection to vision. So
yes, and thank you.
Yeah. Next, Carrie, and we are running a little bit over. Please stay. And we'll finish up with Carrie Van Pelt. Thank you.
Thank you all. And I will go quick because a lot of the information that you just heard is really where we started. I am part of Cincinnati Health Department. I run the first in the nation school-based vision center. And so we kind of did all these things first and got to where we needed to be. We could go next screen. Our entities came together through the public and private sectors, and we wanted to change that trajectory of vision services that were available to our students in our community. Eyes don't hurt, and that's what many people didn't know what we were missing until we did those vision screenings that Dr. King was talking about that are mandated in the state of Ohio. The collaboration between Cincinnati Public Schools and Cincinnati Health Department, our Cincinnati Eye Institute Foundation, Ohio Optometric Association, Growing Well Cincinnati, and one site really brought us all together in 2012. So we just celebrated our 10th anniversary last year. Since then, we've expanded our services to our second school-based location here at the Academy of World Languages, where we see both adults and peds, but we started out with pediatrics. Our evolution and shared successes have been a model for many of the school-based vision centers that are across the country. Next slide. Euler Vision Center, as I said, opened up in 2012, and we service those pediatric patients strictly from 3 to 18 years of age. We have 2 optometrists, 2 licensed opticians, 2 certified para-optometric technicians. The health and dental centers are in a hallway that is dedicated within the school for health services. So we have our own space. We see approximately, because of the 2 doctors, about 4,000 children during the school year. We are not open in the summer at this location, and over 69% of our patients receive eyeglasses. And this has been consistent, and I think Dr. King's statistics were very similar. It's usually 1 in 4 students need refractive eye care. support, because I think we're prioritizing. We also see that significance of the higher number, but because we're in a school, we see all of the school kids, regardless if they fail or pass their vision screenings. And so 50% of our kids are needing glasses, and that's consistent in both of the schools that we do the whole school with. Academy of World Languages opened up in 2019, right before COVID. So we're kind of getting into that routine of where we need to be, but we are servicing the pediatric and the adult populations. So we're trying to learn how do you move both of those populations in a school. And we share our space with the health and dental center. So we have our own waiting room. Here we have one optometrist, 2 licensed opticians, and a para-optometric technician. We see about 2,000 patients. 75% of them are children, 25% are adults, and we do this year round. So our adult patients we see morning and afternoons, and then throughout the school year, but mainly during those holidays, those times off that children aren't around over the summer. That's when we see majority of our adult patients. And again, here's 67% of our patients that need eyeglasses. This is our picture of our Euler Vision Center. Once again, it was supposed to be the library when the school was getting remodeled, and they didn't have enough funding for a librarian. So we were able to take over their space. If you can't see, you can't read. So that's where that thought process came about. And as we shared, eyes don't hurt. It took us some time to get that trust in that community to understand how important eye care was. But once again, we have state-of-the-art equipment. We are set up like a retail space. And we work hand in hand. Our team is a lot of cross-trained, so we are able to navigate if somebody's sick or if the other clinic needs help, we can still keep functioning. And the next slide is our slide of our Academy of World Languages school, and we kind of made this a little bit smaller, a little bit more intimate. We took a little bit of the footprint down, which still allows us to support those same needs, but having a little bit more efficient space. Being able to go in between the 2 rooms with pre-testing and with the exam, and then doing the glasses, being able to have those students right there to be able to take them through at a short period of time. We will transport these kids in to take away the access, the barrier access of transporting. And so we may be seeing 6 students at a time within an hour and a half. Or the rate we're going right now, we are seeing close to 12 students within a 3.5 hour period. And so there's a lot of things that have to move fast to be able to accommodate that. Next screen. So our services that we are providing are comprehensive dilated eye exams that are done by our Ohio licensed optometrists. So Ohio does require licensed optometrists, licensed dispensing opticians. Because of our model as a licensed optician, we transport the children to our facility for the exam, and then 2 weeks later, I'll go back to the school. So we're not taking them out of their academic day again, and actually giving them their glasses when they are in the school when they'll need them. So they have a teacher, they have somebody that's watching them, wanting and kind of showing them why they need those glasses. We have registration, clinical assessments by our licensed para-optometric technicians. We do same-day emergency appointments, and we also have a great relationship with our referring ophthalmologists at Children's Hospital here in Cincinnati, as well as University Hospital, and our CVP Physicians Group, which is another referral for adults. Next screen. How do we start? And I think you guys have all talked about the same issue: is students were failing vision screenings, or they were failing classes, or they just weren't performing the way they needed to perform. So we utilize our school nurses to help us be the voice of that child. And we were doing clinics on a van. We were doing clinics for a 1 week purpose or a 1 week session, but we weren't seeing all those kids that were falling through the cracks. So that's kind of where we needed to come up with those ideas of how do we take care of that gap in vision. That executive committee was planned. I was part of that. So I've seen this from the inception. Even when we were doing vision screenings only. And so really to see this come to fruition has been amazing. But I think a lot of our jumpstart is we had HRSA award us a bond or a capital expenditures. And so that helped us kind of promote this one and done at the time. Continuity of care. You could have this in a school, and how does it work? And we were very fortunate that we really don't pay overhead, because this was one of the things that the schools wanted us to do. Next screen. So our access to care is partnering with that school nurse. That is they are our conduit for their student and our parents. The parent trust them. And so if the nurse is going to say something, that at least gives us the in. We prioritize those failed vision screens, the students that are on IEPs, the teacher, the parent referrals. We really listened to how was this going to, what were the barriers? And we really wanted to take away that access to transportation. A parent may take the child for a dentist because it hurts. They may take a child to the doctor because they're sick. But were they going to take them to an eye exam because eyes don't hurt? How do we do this? How do we prove it? We talked about, and I think in some of the questions here about consents. How do you do this? Well, with our public schools, we were able to partner with the schools as they are enrolling students in to get assigned consent for all those services. Is it medical? Is it dental? Is it vision? Is it transportation? And that goes with them throughout their tenure with Cincinnati Public Schools. So we do updates, but that because of the transient nature of a lot of our children, this allows us, once we've got that consent, we don't interfere with that immediate care needs. So that was one of our main keys to this. And we really are providing proactive healthcare and education. I think the second year we got into having a clinic on site, we had kids coming to us. These were first graders that were asking us, when's my turn to go get an eye exam? I want to come back. And so that was really an eye opener, no pun intended, to really explain the importance of why vision care was there. And I think also COVID was one of that silver linings. Parents and teachers, everybody saw what that kid was doing on their electronic computers and how they were struggling. That started bringing more people in and understanding the need for eye care. And it's building those strategic partnerships to grow the services. And that is either your public sector or your private sector, working with different organizations that will help filter that message to ensure that eyes are taken care of. Next. And so our sustainable model became looking at the prime real estate in the school. How do you do something like this in a school? So maybe it is a room that isn't being used anymore. Our dental services actually took over a closet space and was able to function through that. Academy of World Languages, we were able to get partnership where we actually have a building that is attached to the school so that we could connect to that entity to still have kids have the access to our services. Insurance. And we talked about that. As a federally qualified health clinic, we get insurance, a better rate to help support our operations. And so that is a key to ensure you have that. Connection to a larger healthcare system. Cincinnati Health Department, we have our primary care, our community sites. Somewhere you're going to keep getting that filtered back in. And then you want to look at the potential number of students that you can serve. You want to be in a location that is centrally located, that you can get to. You have parking. You can get to it from a bus. You don't want to put it somewhere where you're only going to have a few appointments, or in a school that only has 200 children. You need to have at least a minimum, and this is kind of where we went into that model, a minimum of 600 students, because that way you can filter if somebody is a no-show, you've got a child that can come in and support that. 80% of those children are consented within the 2 year, or from us, having at least 80% of the students consented so that you can continue to work. And then ensuring that you're in the space with the most poverty rate, so that you know that this is going to be somewhere someone's going to utilize. We also, toyed with, do we only service the students, or do we service the staff and community? And so right now, Euler is still service with students. Staff and community can be more into when we open it up for the adult, but also it relies on your insurance, what insurances you can get enrolled in, and that credentialing does take a long time. So please start doing that now if you're interested in this. Next screen. Here are some of the potential partners that you can utilize. We have national, state, and local entities that you can work with that will be more than willing to give you resources and support your needs to help you get up and running. And then lessons learned. I think we all learned a lot of the same.
You've got about 1 minute.
Yep, lessons learned. I think we all learned about the same entities information, but one of the things that we said is you definitely need to have a vision billing system. Learn those nuances between medical and vision and compliance, because they are different. Have a specific vision electronic medical records system to support your operations. Ensure that there is a consent on your vision. If consent has for vision on the school consents, because that was one of the things we did not have in the beginning. Keep building that trust in the education and awareness in your community. Have a marketing platform that will really help you with the school channels to emphasize the importance of eye care. And be flexibility with your transportation services. We started out having 6 hours of transportation. Now we're down to 4. So how do you do this? How do you work around it? And definitely having cross-trained staff members to support all your facets of your operations. And I think that's where we're at.
Thank you so much. And thank you all our presenters. I think we could have gone easy another hour. And what we're going to be doing is to send out an FAQ with all of your questions. I know there's been a number of questions, and I just want to hand it over to Donna to talk a couple of seconds about resources.
Yep. And I'm just going to take a couple of minutes. Those were just absolutely fabulous, fabulous presentations. Thank you all so much. Oops, hold on. Just want to make sure I'm sharing my right thing. Here we go. So I'm not going to take, I don't know why. Okay, there we go. So I won't take too long, really. I will send these resources out to you. We have several from Prevent Blindness. I'm going to send you our financial resource information. Thank you all for hanging in there. We've got some great, we have vouchers. Carrie mentioned one site who they partnered with. That's one of our sources of vouchers, and also VSP. I do want to mention that Prevent Blindness has affiliates in all these states. So for those of you out there, I hope you will collaborate. I'll send these out with the links to all of our affiliates, who I'm sure will be happy to work with all of you. Thank you all so much for being with us today. And please do reach out if you would like to get any assistance between all of our national organizations who are the sponsors. We would love to be able to hear what you're doing, what help you need. I'm going to guess most of the speakers, our panelists, would also be willing to have a conversation with you if you're starting up services or have some questions. And just want to thank everyone for their time today, and have a great day. Thanks for joining us.